I'm going to speak for 20 minutes. That's my time on laser versus anti-VEGF for ROP. And we'll stop at 20 and then have some discussion. And along the way, please feel free to ask questions or interject or add your expertise. Just a reminder of what type 1 ROP means. This is when we treat retinopathy or prematurity. This is the definition. Zone 1, any stage with plus disease. Zone 1, stage 3 without plus disease. Zone 2, stage 2 or 3 with plus. And I tell the residents and fellows an easy way to remember this is if you have plus disease, you're generally treating. There's rare exceptions, but I don't think I've seen zone 1, no ROP, plus disease, or you actually could have a zone 3 with plus disease. That would be a reason that it wouldn't fit into type 1. I've occasionally seen that, and we typically will treat that if it looks threatening enough in term with neovascularization and so forth. But in general, I tell the residents, if you remember plus disease, you treat, except for here, you don't need plus disease, but everything else is as bad as it can be. It's very posterior, and you have neovascularization. So why keep using laser? Well, the ETROP study showed us good data on why laser is effective. Over 4,000 infants enrolled, 401 reached high risk pre-threshold and were randomized. And here's the flow of patients. Many started at pre-threshold, only some were considered high risk. That was based on an algorithm from the cryo-ROP study where they determined was the infant at a 15% or greater risk for unfavorable anatomic outcome. And if they were judged to be high risk. And that was to try to minimize the number of babies, say with very mild disease, stage 1, zone 1, no plus disease, who might be randomized just based on having pre-threshold status. So only some were considered high risk. Of those, most of them got randomized. Some didn't want to participate. Some didn't have a confirming exam. Most were bilateral cases. That's how ROP acts. When you are type 1 in one eye, you tend to be type 1 in the other eye. There were a few asymmetric cases enrolled as well. And these were the visual acuity outcomes. Primary outcome was visual acuity, and it was defined as unfavorable or favorable. Unfavorable visual acuity meant greater than 4 standard deviations from the mean based on teller acuity cards. Anything else was considered favorable. That was, of course, for the preliminary outcome, and then there were outcomes later at 6 years. Unfavorable visual acuity outcome at 9 months. Eyes treated at high risk pre-threshold, about 15%. Eyes conventionally managed, about 20%. So some of these that turned out with a bad outcome, some of that was based on retinal status, but some of it was based on cortical visual impairment, since many premature infants do have CVI. And here you can see the difference. If we're just looking at unfavorable retinal structure, which simply stated your macula is not right or worse. If you had retinal detachment involving the fovea, if you had total retinal detachment, if you had retrolental mass, those were considered unfavorable outcomes. And the rate was only 9% of an unfavorable outcome. So 91% had good structural outcome in ETROP. And that's one of the reasons that I pointed out, Helen, when we had our point-counterpoint, one of the reasons why people should still consider laser as one of their tools is it works really well, particularly for zone 2 disease. And then here are the 6-year ETDRS data, and it's stratified now by type 1 and type 2. And you can see the difference stands up for the type 1. So if you follow them out 6 years, the rate percent unfavorable outcome was 25%. We had a more rigorous definition to be considered favorable. So unfavorable was worse than 2,200, and there were some kids who met that. But there's still a difference, and that difference is statistically significant for type 1. Interestingly, for type 2 pre-threshold ROP, there was no difference. And in fact, there's even a suggestion that if you treated early, they turned out not as well. So we don't treat type 2. Do you have a question?
Just curious, from a statistical standpoint, how did you deal with the fact that infants who had bilateral eligibility probably were treated the same?
Oh, so I didn't mention. So if you were bilateral, so one eye was randomized to early treatment, The other eye was randomized to later treatment if needed. That is, if they reached threshold ROP, the previous point at which we would treat ROP. So that's how they were handled. And then the asymmetric cases, just one eye enrolled in the study and got either early treatment or treated later at threshold if needed. Exactly. And conventional would be follow. So not all conventional got treatment. Follow, treat if needed. Right. And it, type 1 and type 2 came after the study, right? So that wasn't even part of the study. But looking at the data and looking at the subgroups, it made sense to consider treating type 1. We didn't want to recommend all babies with type 1 ROP need treatment, because if you looked at the fellow eye, those with, for example, zone 1, stage 1 or 2, no plus disease, they tended to get better if you watched them and usually didn't need treatment. So it was in part based on that in defining type 1 and type 2. And Bill Good was the PI for that study. All right, some advantages of laser, high success rate. I hope I've shown you. It's a time-tested therapy. We've been doing it a long time. And it has no systemic side effects. I brought this up. What I didn't say, because I only had 4 minutes the other day, was that although the procedure itself, including sometimes the baby has to be intubated, even if they're not intubated, you're doing sedation, and sometimes the infant won't tolerate the procedure very well, and it can, in zone 1 cases, it can take sometimes for a bilateral an hour, hour and a half to do the procedure. So I've had babies where a couple of times in 21 years we've had to stop in a baby who's just been sedated, and they've had to come and do an emergent intubation. They were doing so badly tolerating the treatment, and then they would get apneic and bradycardic and desaturate. But what sometimes happens is we just need to take frequent breaks. They'll say, oh, I'll give the baby a little break. Okay, let the saturations come back up. And so it's not always simple to do a laser treatment. Some disadvantages: it's definitely more time consuming than injection. It's more costly than a Bevacizumab injection. There's a learning curve. It's not easy. I don't think I was good at delivering laser my first day out of fellowship. I think it probably took a couple of years before I was as good as I think I am now in being able to cover the avascular retina with laser. In fact, I had a retina doc, Jan Kilstra, would come along with me when I was at UNC Chapel Hill, and I'd treat, and then he'd look, and then he'd put in a few spots, and then gradually, you know, you get to a point where he says, no, I think you've done it. So it's not easy to get out to the retinal periphery. There can be challenges to getting an adequate view. The cornea can get cloudy as the procedure goes on. So there's a real learning curve. And the equipment and trained personnel are not available everywhere, particularly developing countries. There may not be a laser nearby for a baby. Even if there is a laser, there may not be someone available who can deliver the laser that day. All right, so why use anti-VEGF? That's when I'll turn it over to you. So I have to remind you, ROP's off-label use of all the anti-VEGF drugs on the list. One of the reasons, can you guys see that picture? One of the reasons is it works really well. The first time I gave an anti-VEGF injection and came back the next day, I absolutely couldn't believe it. The eye looked, and this is 1 day post-injection, the eye looked so much better. I thought, am I looking at the right baby? Okay, yeah, I'm looking at the right baby. Okay, this is too good to be true. It's so fast, because if I lasered an eye and it looked that good 2 weeks after laser, I would be delighted. Okay, but these eyes look this good the next day, usually. And here's the left eye, same thing. Pre-injection, post-injection, big changes in the posterior pull. Now, the neovascularization also improves rapidly, but typically not by the next day. Is that your experience, Helen? Depending on how thick it is, right? If it's thin, you see it improving a lot already. Right. You were saying that's one thing that makes people think there's a recurrence if thick neovascularization is not going away, but it's not necessarily a recurrence, right? I'm repeating things you guys say because it's videotaped. All right, here's some advantages of anti-VEGF treatment. It really is a more direct approach to blocking the effects of VEGF on the retina. It's a VEGF antibody. You have VEGF there causing neovascularization. You bind it with antibody, VEGF can't work. Laser, on the other hand, is more indirect. Let's destroy the retina that's contributing to the production of VEGF, and then eventually the VEGF that is in there will be used, and so forth. So it's less time consuming, less expensive. Several studies have reported rapid resolution and high rates of success. And I think this is big, and I think your data was, and I have a slide with your data from the Beat ROP follow-up showing much less myopia after anti-VEGF. So what about efficacy of Bevacizumab? This is Dr. Mintz-Hittner's study, Beat ROP, randomized multi-center trial. Zone 1 or posterior, Zone 2, stage 3 plus. They received this dosage versus laser. Infants were randomized. Here's the primary outcome, recurrence of neovascularization in 1 or 2 eyes, requiring retreatment by 54 weeks. And here's the outcome. The results showed in Bevacizumab, 6% of infants had recurrence. In laser, 26% of infants had recurrence. This shows you both eyes versus one eye. For Zone 1, the difference was statistically significant. For Zone 2, it was not. Some limitations have been pointed out by Dr. Mintz-Hittner, and some of her presentations as well will point out some of these. The primary outcome was recurrence of neovascularization. So that was dependent upon treatment decisions by investigators who practically couldn't be masked for the study unless you had a whole cadre of investigators able to do that. Recurrence of neovascularization is an important short-term outcome, and that's one we're using in the ROP1 phase 1 dosing study. But I think we all agree it's not as relevant as visual outcome. I believe anatomic outcome was a secondary outcome in your study, correct? And there were high rates of laser retreatment in this study. And an insufficient sample size to really make any conclusions about systemic side effects. I'm not sure we'll ever have a randomized trial that will have sufficient sample size to be able to make firm conclusions about things like death, for example. But we may be able to get at things like neurodevelopment later on with large enough studies. The high rate of laser retreatment meant when there was a comparison to the rate of recurrence with Bevacizumab, it allowed it to be statistically significant. If I said that correctly as a statistician, the difference was large enough that you didn't need hundreds of patients to show a difference. Right? Look at these myopia results. I mean, I was asked to give the discussion at APOS a few years back, and I think it was one of the doctors working with you who presented these results, and I gave this discussion. And, you know, for me, this is a wow moment. So, Zone 1 eyes, Bevacizumab, mean myopia about -2 versus -11, 2 years after treatment. Zone 2, -0.6 versus -5.6. Maybe anti-VEGF treatment allows for less disruption of growth factors that might be important for anterior segment development. Most myopia in ROP tends to come from increased lens power, based on what I've seen, although you can have steep corneas. Here's a guy, Bob Gordon back there, who knows a lot about refractive error and contribution of lens power, cornea, etc. Do you agree or disagree with lens power being a big factor? Shaking his head yes. He's actually saying no, but since, you know, I'm the only one being recorded. For the record, everybody's agreeing with what I say. Meanwhile, you guys are. There are some disadvantages or risks of anti-VEGF. Small risk of endophthalmitis. My colleague Scott Lambert at Emory described they had a baby sent in after ROP injection and had endophthalmitis. I haven't seen a case personally. Have you seen any cases? No. There's some unknowns. Late recurrence. We're learning more about late recurrence. Your paper was recently published, wasn't it, in ophthalmology? September of Ophthalmology, showing a late recurrence rate, is it 8%? Roughly 8%. And I would encourage you all to look at that paper for more details. But Dr. Hittner describes beautifully some of the things to look for. You know, for late recurrence, it can occur at the ridge, it can occur posterior to the ridge, and the peak time seems to be between about 50 and 55 weeks for recurrence. 45 to 55, so a larger range. What's the effect on macular development? Maybe it's positive, maybe it's negative. I think we don't know until we get visual acuity outcomes when the kids are older. Is that coming? It's coming. Stay tuned. What are the effects on developing organs? That's the thing that a lot of neonatologists and ophthalmologists are talking about. We want to make sure we're not harming the baby. Here's the Italian study. I showed this the other day at Subday. They had 13 infants. One eye got bevacizumab, one got laser. And the bevacizumab patients had some irregular vascular branching. They had large peripheral shunts, as you see over here. They had some absent capillary network and some persistent avascular retina and some odd choroidal filling patterns. So they found on fluorescein that there were more abnormalities with Avastin than with laser. And you know, we often see nice progressive vascularization out toward the periphery with these babies, but sometimes those vessels look very abnormal. And there can be areas of capillary dropout between the big vessels. And so I think what we really don't know yet is the retina around those abnormal vessels developing into normal retina that's going to function well later. If it is, then probably we're going to see much better peripheral visual fields after bevacizumab than after laser. If it's not, then maybe we won't. It gets in the systemic circulation. One study showed peak levels 2 weeks after injection, detectable up to 60 days. There's large reductions in serum VEGF levels up to 6 to 8 weeks after injection. One thing I learned recently is premature babies have higher than normal VEGF levels to begin with. So if this is where you're supposed to be, but you're premature and you're up here, and we give Avastin and you go down here, is that bad? Maybe that's not bad. Maybe it's okay to be down here, or maybe you need high VEGF levels for some reason to help in your development if you're born prematurely. I talked to a neonatologist this week about it, and he didn't know. He sent me to some references to read about it. Why is it in the systemic circulation so long? Vascular endothelial cells actually will endocytose full-length antibody and slowly release it, and that's really nature's way to prolong half-life of total antibody in the circulation. Whereas Lucentis is just an antibody fragment. It doesn't have this mechanism, and so it's cleared out very rapidly. This was an important paper. I'll be at McGill next week talking about ROP, and I hope to meet, I know Roseanne will be there, and I hope to meet some of the other investigators of this study that found a difference in neurodevelopmental outcomes in babies treated with bevacizumab compared with laser. It was a registry. The numbers were relatively small for Avastin, and they noted worse motor development in the Avastin-treated infants, 81 versus 88 on the test that they used. That difference was statistically significant. Now, I want to mention they looked at several outcomes, and this was the one that was different. Sometimes, as you know, Dave, if you look at several things in any study and you don't necessarily define one as your primary, you may just by chance find a difference somewhere. Right. Right. And so thank you for that lead-in to this next point. And that is that the study was really limited by its observational design. So it wasn't a randomized trial. It was a registry of how they had treated babies. And the sicker infants with the worse ROP tended to get Avastin. And that makes sense in an observational design, because sometimes we're looking at a baby and we're making a decision, should I laser or Avastin? Well, it's a zone 1 case. They're probably going to do better with Avastin. Or well, I could go either way, and the neonatologist says, this kid's pretty sick, and I don't know if he'll really tolerate a laser. Can you do something a little quicker and less stressful for the infant? say, sure, yeah, we can give an injection. And so I think this study, and the authors acknowledge that in their discussion. I think they're very transparent about their limitations. But studies like this make us wonder whether we're doing any harm systemically. So here's some options. Maybe just use Avastin when there's a poor view for laser. Most of us have moved beyond that. Maybe only a salvage treatment. No, I don't think many people do that. Only for cases of very posterior zone 1. I think almost everyone does that now. If you look back and there's just what Sharon Friedman, my associate, calls the postage stamp. You see an optic nerve and you see just a few blood vessels that have gone out, not even as far as where the fovea would be. And your heart sinks because it's a severe case. I think almost everyone would use Avastin in that case. All zone 1 cases, many people I think have gone to that. As primary therapy for all type 1 cases, maybe. That our eligibility criteria for a phase 1 dosing study was all type 1 cases. So we'll see. This is a big question in my mind. And I hope we'll get some answers over the next few years. Should we laser these kids later? When should we laser them? Who should be lasered? I was giving a talk in West Virginia recently, and the retina doctor at the university there said, my patients are high risk to not come back. I laser all of them after Avastin before they leave the nursery. I just can't risk that they're not going to be able to come back and they're going to get the late recurrence of disease and retinal detachment, and I won't know about it. But we're doing it selectively at Duke. So if we begin to see signs that there's recurrence, maybe we're seeing some pre-plus disease, we're seeing vascular abnormalities at the vascular-avascular junction, we'll sometimes laser those kids. Personally, we don't use fluorescein. Some centers will take those babies to the operating room, do an exam under anesthesia, do fluorescein angiography. Are you utilizing fluorescein for those? You do. Right. So Dr. Hittner said at the bedside, they're sometimes doing fluorescein with sedation. That's a great idea. PEDIG is doing a phase 1 dosing study of Bevacizumab for treatment of severe ROP, and here's our objective. We want to find a dose that's lower than is currently used for severe ROP, is effective in a small study, and can be carried forward into larger studies. Most phase 1 studies for drugs or for new drugs are done as a dose escalation. That is, you start with a low dose, and you want to be in the study, and I'll give you a low dose, and you did fine, let's do more. Let's do more, and typically looking for toxicity and effectiveness. We couldn't think of a good way to do ROP like that, and in fact, we were worried that we'd give too little drug and the babies wouldn't respond, and as you know, ROP is high stakes. You sometimes just have a few days to get an effective treatment, and so we designed a dose de-escalation study. We started with 0.25, which is 40% of the dose used in the BEAT-ROP study, and went from there. And so type 1 in 1 or 2 eyes, no previous treatment for ROP. You could have laser of one eye and still the other eye could be in. 10 subjects were treated with this initial dose. It was 0.25 in 10 microliters, which is undiluted, just as it comes. For infants with bilateral type 1, one eye was randomly selected and called the study eye, and the other was the non-study eye. If the non-study eye also required treatment, the investigator could use laser or could use Avastin. So how did we do Avastin in the other eye? If they gave Avastin in the other eye, we decided to give them the last effective dose in the study. So what does that mean? If you started with 0.25 in the study eye, we gave him 0.625 because we wanted to make sure at least one eye was getting something that worked in the non-study eye. If 0.25 worked, we tested half that, and the non-study eye got 0.25. If that worked, we tested here, and the non-study eye got here. We didn't want to be here because we didn't want both eyes to get ineffective treatment. We didn't want to be here because of crossover. We were trying to minimize crossover, and so that's why we designed the study that way. You ask about the syringe. This is a syringe that we're using. It's, your standard TB syringe is 1 ml. This is 30% of that. So this is 300 microliters, and we really like this syringe. It's got a fixed 30 gauge needle. It's 5 5/16 of an inch, I believe. So it's safe. You can bury the hub, and you know you're not going to touch the retina. And it's easier because it has less volume. It's easier to actually deliver 10 microliters. And we thought about before the study started, you know, we could choose the volume we want to give because we're diluting, essentially. It's being prepared by pharmacies and diluted when we go lower. So you can dilute it however you want and choose a volume. We decided we thought we could effectively deliver 10, but probably not 5 or 2 or 1. That would have been hard. Here's our primary outcome. It's success or failure by 4 weeks. Of course, what matters beyond 4 weeks is important, but we had to choose a primary. And this seemed most important to us because if most babies are successful by 4 weeks, we know we've suppressed disease. Maybe some need treatment later. And I think that's going to factor in ultimately to what dose we choose. Because if 3/4 of the babies need retreatment, probably that's not enough drug. But if 25% or 10%, then maybe that's arguably enough drug. We had a specific definition for failure. Failure is confirmed by a second examiner. Basically, you had to get better by 3 to 5 days. If you weren't, you were out of the study, so you could get whatever treatment you needed for both eyes right away. We have a DSMC. After 10 to 14 infants are treated. Why 10 to 14? Because when the 10th is treated, the clock starts for their 4-week outcome. And then for 3 weeks beyond that, we can recruit up to 4 more. And that way, if a baby dies or a baby can't have an exam or has lost a follow-up, we make sure we have at least 10 in the group. So the DSMC is reviewing, and they're telling us, can we go to the next dose? Do we repeat the same dose? You could do 1 dose twice if we were in uncertain territory. Do we increase the dose, or do we end the study? So that study just completed enrollment. We're just now looking at data. We hope to report it at APOS in the spring. And the writing committee is beginning to meet, but I can't give results yet for the study, but I think we'll have them soon. So anti-VEGF or laser in 2016, it depends. Oh, please. Well, absolutely. Right. Can we correlate failure with severity of ROP in the study, with the initial severity of ROP? And so the answer is we'll try. Because the numbers are relatively small, some doses only had 10 babies, 12 babies, but if a dose was repeated, we'll have 20 to 28 babies, and we may be able to say, 10 zone 1 babies, and we had this, this success rate versus the zone 2s. So we'll try. So in 2016, is it very posterior? Is there a poor view? I think we would all use anti-VEGF. Do you have prompt access to laser? Are you good at it? Do you get good results? That's really important. What type of anesthesia do you need for laser? I've worked with some investigators in the study whose hospital requires the baby go to the operating room and have general anesthesia for laser. I mean, if my hospital required that, I probably wouldn't laser very much. And finally, and I think this is really important, is the family likely to attend follow-up appointment for months after treatment? So recurrence can occur up to 65 to 70 weeks. And did I even see something that someone was reporting 2 years later? I see. So Dr. Hittner's saying if you inject and you inject and you inject again, you're driving out the time that you can see recurrence. You're really resetting the clock, right? So those babies would have to be followed even longer. But because you can get recurrent disease and need additional treatment, we're seeing these babies weekly in the hospital. They go home. Sometimes we're seeing them weekly at first if we see any worrisome signs. Then we got brave and went to every 2 weeks. And we typically do that until this 45 to 55 week time period when they're at highest risk for recurrence. After 55, I'll sometimes go to 3 weeks if I see no worrisome signs. Or if they get full vascularization, you know, we can stop seeing them then. But the parents have to commit to that, and that's an important part of the discussion I have with them. We can't be trying to chase down babies and families week after week after week who are at risk for recurrence and retinal detachment. So that's an important point. Future directions, there's a lot we still need to learn. There's a lot we have learned. The more we know, it seems the more we don't know. More questions come up. And I think there's many opportunities for all of us to do high quality comparative studies and to add to what we know already about anti-VEGF treatment.